All right, welcome back to the Explainer, everyone. For all you USMLE learners out there grinding away, you already know the deal. Time is literally your most valuable asset. You don't just need to memorize a bunch of facts. You need to recognize patterns, and you need to do it fast. So today, we're tearing into a super high-yield, absolute classic clinical vignette. We're going to break down the text, analyze the data, and build a mental model so rock-solid that the next time you see this pattern on test day, you'll instantly know the answer before you even glance at the options. Let's get into it.
Okay, picture the scenario. You're in the ED and a 34-year-old woman presents complaining of severe headaches and a racing, pounding heart. But here's the catch. It comes and goes. This isn't just a constant, dull throbbing. We're talking about a sudden, episodic attack. Now, as a diagnostician, your mind should immediately start categorizing. Episodic, severe, young patient. What on earth is the underlying mechanism here? Keep that in the back of your mind as we reveal the rest of the clinical picture.
So take a look at this authentic USMLE-style setup. We've got our 34-year-old woman with recurrent episodes of severe headache, palpitations, diaphoresis, and tremor. Notice the timing here, guys. This is crucial. The episodes last 10 to 20 minutes and happen several times a week. During one of these attacks, her blood pressure spikes to an alarming 190/110 with a pulse of 118. But check out her physical exam between the episodes. Totally unremarkable, completely normal. Her lab testing, however, shows elevated plasma-free metanophrines. So before you just jump to an answer, really think about it. Are we looking at primary hyperaldosteronism, pheochromocytoma, hyperthyroidism, panic disorder, or carcinoid syndrome? To crack this case, we have to separate the signal from the noise. And the absolute loudest signal here is the classic symptom triad. First up, the headache. Second, the palpitations. And third, the diaphoresis, that intense, drenching sweat. Whenever you see these three specific symptoms grouped together in an episodic fashion on the boards, a massive alarm bell needs to go off in your head. This triad right here, it's the hallmark presentation of a very specific, incredibly high-yield endocrine pathology.
And that pathology is our correct answer. Choice B, Pheochromocytoma. So what exactly are we dealing with here? By definition, a pheochromocytoma is a rare catecholamine-secreting tumor derived from the chromophene cells, which are located right in the adrenal medulla. Think of it like a rogue factory. It's essentially this tumor just pumping out massive, totally unregulated amounts of stress hormones straight into the patient's bloodstream.
Let's break down exactly why this is the definitively correct answer, because it honestly hits every single diagnostic checkpoint perfectly. Number one, we've got our classic triad: headache, palpitations, diaphoresis. Number two, paroxysmal hypertension, those wild blood pressure spikes during the attacks that heavily suggests massive surges in catecholamines. Number three is the lab clue. Seeing elevated plasma-free metanophrines is a dead giveaway, because metanophrines are literally the breakdown products of those excess catecholamines. And finally, number four, the intermittent spells. The fact that she's totally fine between the attacks perfectly aligns with symptoms happening in sudden dramatic bursts rather than just a steady, constant streak. So the really crucial point here is understanding the main driver behind all this physiological chaos. And it all boils down to three words: excess catecholamine release. That is the biological explanation for literally every single physical symptom this patient is going through. When that tumor squeezes out a massive surge of epinephrine and norepinephrine, the entire body goes into a sudden, totally unprovoked fight-or-flight overdrive.
And this brilliantly illustrates that exact mechanism. If we trace it from the anatomical source, we start right there with the chromophene cell tumor of the adrenal medulla. That tumor directly causes step two, the excess catecholamine release. That huge surge gets dumped right into the blood, which brings us to step three, this intense episodic sympathetic activation. Finally, that systemic sympathetic storm manifests as step four, the physical symptoms we saw in the vignette: the headache, the palpitations, the diaphoresis, the tremor, and of course that severe hypertension. It's really just a perfect logical chain of cause and effect. Now, you guys know a top-tier test taker doesn't just memorize the right answer, they know exactly why the wrong answers are wrong. So let's look at choice A, primary hyperaldosteronism. Why doesn't this fit? Well, yeah, hyperaldosteronism definitely causes hypertension, but it causes persistent hypertension, not these sudden 10 to 20-minute spikes. Plus, if it were primary hyperaldosteronism, we'd expect to see distinct lab findings, right? Like hypokalemia and metabolic alkalosis, and none of that was present in our patient. Our patient is having episodic catecholamine spells, so we can totally rule this distractor out. Okay, what about choice C, hyperthyroidism? Now, this one is a tricky distractor because hyperthyroidism absolutely can cause weight loss, tremor, and palpitations. But again, you got to look at the timeline. Hyperthyroid symptoms are usually way more sustained. You don't typically see a patient completely revert back to a totally normal baseline for days at a time in between quick 15-minute episodes. And on top of that, a hyperactive thyroid does absolutely nothing to elevate your plasma-free metanephrines. That lab clue points us squarely away from the thyroid and straight toward the adrenal gland.
Let's just quickly sweep through those last two distractors to make sure our reasoning is totally bulletproof. Choice D was panic disorder. Sure, a panic attack can definitely mimic the palpitations and the sweating, but a panic attack is not going to explain a severe hypertensive crisis of 190 over 110, and it definitely won't elevate catecholamine metabolites in the blood to the level of a tumor. Lastly, choice E, carcinoid syndrome. Yes, this is another tumor, but it typically secretes serotonin, not catecholamines. So you're going to see flushing, diarrhea, and bronchospasm, rather than that classic, pressure-heavy Pheochromocytoma triad. The ultimate key separator here is always that severe episodic hypertension combined with those elevated metanephrines.
All right, to really lock this in, here is a fantastic, super easy memory aid that you can take straight to test day. Just think of the P in pheochromocytoma. Pheo equals pressure, representing that severe paroxysmal hypertension. It equals a pounding heart, representing the palpitations and tachycardia. And it equals perspiration, representing the diaphoresis. Pressure, pounding heart, perspiration, the 3 Ps. If you see those 3 Ps on a question, you're almost certainly looking at a pheo. Now, what's really interesting here, and you know the board examiners love to do this, is testing those extra layers. You didn't actually think they'd just stop at the diagnosis, right? You have to know the common associations. Pheochromocytomas very frequently show up alongside specific genetic syndromes. MEN2, von Hippel-Lindau, and neurofibromatosis type 1. Definitely memorize those links. But honestly, the most critical, literal, life-saving clinical pearl here is the treatment rule. When prepping these patients for surgery, you absolutely must give alpha-blockade before beta-blockade. If you give a beta-blocker first, you leave those alpha receptors completely unopposed to the massive amounts of catecholamines, which can trigger a catastrophic, lethal hypertensive crisis. So say it with me, always alpha before beta. So let's pull all this together into your ultimate high-yield take-home points. Number 1, your classic clinical clue is the episodic headache, palpitations, diaphoresis, and marked hypertension. Number 2, the definitive biochemical test is finding those elevated plasma-free metanephrines. Number 3, always remember your syndromic links, MEN2, von Hippel-Lindau, and NF1. And number 4, the absolute golden management pearl, always administer alpha-blockade before beta-blockade prior to surgery. Which brings us to our final test day equation. Episodic sympathetic storms plus elevated metanephrines equals a pheochromocytoma. Every single time. Look, at the end of the day, pattern recognition isn't about memorizing massive paragraphs of text. It's about connecting clear, distinct data points into an undeniable conclusion. If you can master this equation and truly understand the deep pathophysiology of why it happens, you're not just memorizing an answer, you're owning the concept. So think about it. When test day finally arrives, how many more impossibly difficult clinical vignettes will you crack just by recognizing the underlying biological story? Keep studying smart, keep grinding on those patterns, and I'll see you in the next explainer.